So after listening to Kalpesh, I'm glad I'm retiring in a couple of years because between robotics and arthroscopy, there's going to be very little left for regular orthopedic surgeons. So I'm going to talk a little bit about the pylon fracture, and since my topic is on what's new, it's going to be basically touching on a few things which I think are still important and a few things which are new. So the key points that we're going to talk about are things which remain true today. We're going to talk about some of the newer classifications, how we understand these fractures, the approaches, and the management. So I think really the most important lesson we've learned over the last few decades is that the soft tissue injury dictates the plan of management. So if you don't, or if you ignore the soft tissue, that's going to be what you will end up with, and it's going to be a disaster. The classification, I think the time-tested classification is that of Rudy and Algova, which was way back in 1968, based on ski injuries that he saw. And I think things have changed a lot because many studies have shown that these classifications do not stand the test of scrutiny with poor observer, inter-observer, and intra-observer reliability, which meant that they were not useful research tools. So with the advent of CT and the fact that CT is really become essential for management of all pylon fractures, we now have the CT-based classification, the first of which was by Margaret Topless from the UK, and this was basically based on various fragments of the injury, whether it was anterior, medial, posterior, posterolateral, anterolateral, or whether it was a punch fragment. And she divided them into various fracture families based on whether they were sagittal, posterior coronal, or anterior coronal. There's also a new CT-based classification by Leonetia et al., which is looked at the various fracture in various parts and the columns that are involved. And you now have a staged procedure protocol based on the 4-column concept in the treatment of pylon fractures, just as you have in the proximal tibia. One of the things that has changed is that in the initial management where you started the staged protocol, you would also fix the fibula at the same time. Now with the newer approaches, you tend not to fix the fibula in the initial external fixator application. You just use a spanning fixator and then do your definitive procedure, which at the same time you would fix the fibula. There's also been mapping of these fractures. So where are the main areas where these fractures take place based on the pressures that the ankle undertakes under these loads, and also the ability of distal tibial plates to stabilize these fractures. So there have been a number of studies which have looked at how these fractures can be stabilized and where you would need 2 plates or more plates to stabilize this fracture. Now, the importance of CT is in 2 things. One is in studying the fracture geometry. So you can't understand this entire fracture if you saw those X-rays and you look at the CT. And also in identifying the key fragments. You need to look at the CT, especially the axial cuts, very carefully to understand which fragment it's important to reduce before you do your fixation of the fractures. Now, another old concept which still bears the test of time is what happens to the fibula. So the fibula can either fail in tension or in compression, or it could be intact. So if it's a tension failure, that means the ankle goes into varus, then your buttress has to be on the medial side. As opposed to this, if your fibula fails in compression, then your buttress has to be on the anterolateral side, as you can see in this case. The approaches, now we all grew up with this AO concept of 2 approaches, one for the fibula and one more anterior, leaving a bridge of about 7 centimeters below this. I think today this has changed drastically with you having to approach the fracture through various approaches which you have to familiarize yourself with, and approach the fracture from wherever you can best approach that fracture fragment. So there are various alternative approaches which have been described. The anterior extensile approach is one. The lateral approaches where you can deal with the fibula and the tibia through the same approach. There have been two different descriptions of this based on the angiosomes involved with the skin. And more recently, a posteromedial approach, where you approach the posterior fragments through a posteromedial approach, which just goes medial to the tendoachilles and leads you down to the bone just lateral to the vessels, where you can fix the tibia and the fibula with, and then you turn the patient around to deal with the anterior part of the fracture through an extensile anterior approach. So basically, the fracture dictates your approach. So in a fracture like this, which I showed earlier, you can use this extensile lateral approach. This will allow you to fix the fibula, also reduce the articular surface of the tibia, accurately visualize it and fix it so that you get a good reduction and fixation, which will then end up with a good result. This is at 3 months post-op, and this is at 4 years post-op. You should see a good, excellent result of the ankle with good movement, etc. Now, in spite of all the sort of advanced learning with these fractures, unfortunately, the outcome of pilon fractures, especially the high-energy pilon fractures, is still not so great. A low percentage return to manual labor by 6 months, and the quality of life is dramatically reduced. So various studies have looked at quality of life and at the number of patients who can go back to manual work, and the results are not that satisfying as you might think from the various new techniques that we have come across. So in conclusion, remember that the soft tissue injury, you need to assess the fracture geometry. You have to familiarize yourself with all the approaches and use the appropriate approach for the fracture pattern. So you can have an algorithm decision-making chart based on the displacement, whether it's normal bone, the soft tissue, and based on all this, you can decide on whether you're going to do a staged procedure, you're going to use lock plates, you're going to treat conservatively or operatively, and where you might use just frames. So eventually, I think the most important take-home message is that the pilon fracture, especially the high-energy pilon fracture, is really a soft tissue injury with a concomitant fracture. And I think this is the most important lesson to remember at the end of this talk. Thank you.
You can invite questions.
Sure.
So wonderful talk as always. The most beautiful thing you said probably was you skimmed about angiosomes and the lateral approach. So this work probably has done by Tanavat Vasinen, who is also a member of our
Yes,
APUF.
so it's Femino and Vasinen. Vasinen is from Thailand, and Femino is from the UK.
Correct.
US, sorry.
Okay. So could you, sir, elaborate for the benefit of rest of us, elaborate upon those angiosomes and how exactly you take that view? Because of late, that is the approach which is gaining much traction. The workhorse still is the anterolateral approach, but that lateral approach based on angiosome, could you, sir, elaborate on that?
So the original, so there were two extensile lateral approaches described. The first was from the Hospital of Special Surgery in New York, where the incision was anterior to the fibula, and it took the same track towards the fourth metatarsal base. Now, Femino and Vasinen did studies, and they found that if you really went by the angiosomes, you had to literally do your incision on the posterior border of the fibula. You went down and you still tracked it again towards the base of the fourth metatarsal. And along with that incision, you took off all your muscles with the muscles all the way across, anterior to the syndesmosis, superficial to the periosteum. So it was in a submuscular extraperiosteal space where you took everything off across from the lateral side to the medial side. So you got full exposure of the entire distal tibia and the fibula, which you could plate through the same approach. So that's the advantage. We've actually extended it further to actually do the posterolateral plating or the posterolateral plating through the same approach with the same incision. So we go distal, posterior to the peroneal muscles, between the peroneal muscles and the flexor hallucis longus, and go to the posterior surface of the tibia. So we can actually put plates all around the fibula except for the extreme medial side through this one approach.
Correct, sir.
Yeah.
Good morning, sir. Sir, when there is associated syndesmotic injuries with these spinal fractures, now with the presence of more, apart from the screw that we used, soft tissue implants also using fiber tape and similar sorts. So my question is, what is your choice of implant for stabilization the syndesmosis? How much tightness, how much compression you want at the syndesmosis? And do you, sir, remove it after 2 months or just leave it?
So, interestingly, the pilon fracture is often not associated with a syndesmotic injury, unlike the ankle fractures. Okay, so very often in the pilon fracture, you may have bony fragments of the syndesmosis, but very rarely have a ligamentous injury of the syndesmosis. So you don't really very often have to use syndesmotic screws or tight ropes. Okay, now in ankle fractures, my personal preference is still for screws. We tend to use 3.5 screws, 2 screws if necessary. We tend to leave them. We tell the patient that it's going to break when you start walking, but we don't bother taking them out. As long as you've explained that to the patient and told them that it's nothing to worry about, usually it has not been a problem. So we just, if it breaks, we take out the lateral part of it, we leave the medial part of it in the tibia.
So many a times, sir, how much compression do you take? And many a times it
So
does
you
not break.
you compress on the table to get reduction, but you don't use lag screws. Okay, that's the usual pattern.
So if you are using a screw, there is chances of that it's remain in the malreduced position. The advantage of suspensory fixation over a screw is that even if little bit of malreduction is there, with the time it get reduced with the suspensory fixation like tight rope. The problem in the reduction is that most of the time you fix with one head of that reduction clamp is over the fibula, another with the tibia. So there is direction of that. It should be in the upper 1/3 of the tibia. It's not in the middle or it's not in the posterior part in the lateral view.
I think the key is visualizing your reduction.
Yeah.
So you have the Mercedes-Benz sign at the bottom. So you actually open the syndesmosis there and look at it to visualize your reduction, because the only way you can assess your post-op reduction is through a CT. And by then it's too late because most of us don't have CT in the OR. Okay, so what's important is your reduction of the syndesmosis. But again, like I said, this is not something you commonly see in pilon fractures. Okay, so so it's a different topic altogether, which will be, I'm sure, covered by the people who are talking about the ankle. Okay.
Sir, one more question.
Yeah.
Like, what's your tips and tricks to avoid the skin flap necrosis in anterolateral approach? And the length of the plate, like in medial MIPO technique, we use long plates. But anterolateral, we are unable to use long plates.
Yeah,
so ideal length.
So the thing is, with this lateral approach, you can use long plates. Okay, because it's open. You're not sliding your plate. If you slide your plate, there's a limit of about 8 to 10 centimeters where the superficial peroneal nerve will come in your way. So if you're doing this open approach to the lateral approach, you're actually visualizing, you visualize the superficial peroneal nerve and protect it, because the superficial peroneal nerve is very variable in where it comes out. So with this approach, you can actually visualize it and protect it. So that's one thing. Second thing is, sorry, what was the question about?
Skin flap necrosis.
Skin flap
and the length of
So the
plate.
skin flap necrosis goes back to the same thing about waiting long enough before you do your surgery. Okay, so you have to wait for the soft tissue to settle down. Now this time could vary anything between 5 days to 21 days or even longer in certain situations. And that is the importance of putting on an external fixator and getting a provisional reduction before you do your final surgery. Because this time is very variable and you get impatient and you operate early, and that's when you have your problems with the skin flap. So I think you have to wait long enough till you get the wrinkling, all the blisters have healed, and the soft tissue has completely settled down before you do your surgery. So that's the best option for that, for any approach, whether it's anterior, lateral, anterolateral. In all these, I personally feel that you should wait. There may be a time interval within the first 6 hours where you can get away with early surgery, but we never get patients within that time.
Continuous with that question, if you are using the interolateral plate along with the fixation of the fibula plating, so do you use single incision or go for the 2 incisions? What is your
No,
preference?
so that's what I'm saying. So this approach allows you to fix both. Now the number of incisions you make would depend individually on the pattern of the fracture. Okay, so for many of these, we just use one incision to fix both the fibula. So if you have to put an anterolateral plate on the tibia and a fibular plate, we can do that through one approach. If you have to put a medial plate, then we would use two approaches. Okay, this medial approach may be MIPO. Okay, so depending on the fracture pattern, you could use a minimally invasive approach for the medial plate. But if you need to visualize the articular surface on the medial side, then you do an open approach. But then you leave enough skin bridge because your one approach is lateral and one approach is medial, so you have enough space between the two
So
skin.
using single incision plating interolateral and the fibula,
Absolutely, no problem at
no
all.
problem at all.
Yeah.
Thank you,
Sure.
Dr. John Mukhopadhaya, sir. Our next speaker is Dr. K.S. Anand, sir. His lecture is on list